Good afternoon, respected judges and all the delegates. I'm Dr. Komal Singh, PG resident from AIOCMTC1, presenting a paper on the topic Ocular Effects of Refractive Error in Children or Pediatric Population. I have nil financial interest. So an easily detectable and correctable condition like refractive error still remains a significant cause of avoidable visual disability in our world. In India, it is considered as the most common cause of blindness after cataract. Accommodation and version system have a great role in maintaining binocular single vision through their components such as accommodative response, facility, amplitude of accommodation, near point of convergence, negative and positive relative accommodation, and negative and positive fusional versions. So treating myopia in infants is usually unnecessary, but children should be corrected with spectacles or contact lenses. There may also be asthenopic symptoms in emmetropic eyes, especially in this COVID era, where a whole of the education system has been shifted from classroom to digital screens, which has led to development of disorders like convergence insufficiency and poor accommodation, which is treated with orthopic exercises. So the aim of the study is to study the effects of refractive errors on asthenopia, accommodation, and convergence. Subjects for this study were selected from the patient attending the pediatric ophthalmology clinic in tertiary care center, eye care center, as per the inclusion and exclusion criteria. And it is a hospital-based cross-sectional study, which included the patients of 2 to 18 years of age group. Total sample size was 270, which is further divided into 3 groups. Group 1 included 90 subjects with no refractive errors. Group 2 included consecutive 90 cases of myopia plus minus astigmatism. And Group 3 had consecutive 90 cases of hypermetropia with or without astigmatism. So population of age group 2 to 18 years, patients with uncorrected or no refractive error were included in the study, and subjects who were uncooperative for refractive error or detailed orthoptics evaluation were excluded from the study. So the results, I found that the almost 98% of the subjects in emmetropia group were presented to the OPD with the asthenopic symptoms, while around 70% of the myopes exhibited symptoms of asthenopia. And around 40 to 45% of subjects in myopia group had asthenopic symptoms. In accommodation, in mean binocular NPA was worst in hyperopes, which was measured to be around 17 centimeters, which is followed by emmetropes, which is around 11 centimeters, and in myopes it was around 10 centimeters. Facility was almost comparable on the the 3 groups. PRA was also comparable. It was slightly on a higher side in myopes, and NRA was slightly on a higher side in hypermetropes. So disabling asthenopic symptoms were associated with uncorrected refractive errors, defect in ocular motility, and accommodative or convergence insufficiency. So the presence of asthenopia was significantly more in emmetropia group as compared to refractive error groups, and this can be due to higher visual demands in emmetropic patients as compared to emmetropic ones, for which they need to visit the hospital. Asthenopia in emmetropes is due to accommodation and convergence insufficiency. A study concluded that the lower degrees of myopia, hypermetropia, and astigmatism are the major causative factors for asthenopia. Asthenopia in myopia is due to the patient has to rely on increased positive fusional versions for single vision to near point in order to replace the absent reflex positive accommodative convergence. While asthenopia in hyperopia is due to the excessive accommodative response, which leads to increased ciliary muscle tone to attain the single vision to near object. The NPA in emmetropes is poor, which explain why these patients present to OPD with asthenopic symptoms. Such patients are unable to accommodate without the help of convergence. And higher value of NPA in hyperopia is because patient overuses accommodation. Facility is comparatively reduced in myopia and hypermetropia because of poor accommodative response in myopia and poor divergence insufficiency in hyperopia. Higher value of NRA in hyperopia is attributed to requirement of higher convex lenses to relax the excessive accommodation hyperopia. MEM retinoscopy in group 2 suggests the lead of accommodation, which justifies the excessive accommodative response in myopes, while MEM in group 3 points towards the lag of accommodation, which further explains the loss or the reduction of accommodative response in hyperopes. Mean convergence was significantly more in myopes and hyperopes as compared to the no refractive error groups. So I conclude that the presence of asthenopia was significantly more in no refractive error group as compared to refractive error groups. The limitations were, as it was a tertiary eye care center, so our population may not represent the entire Indian population, and it was a cross-sectional study. And it was done with the patient wearing the full refractive correction in the trial frame, so the precision in the values like NPA, NPC may have been compromised. These are my references.